Good evening, everybody. My name is Roxanne Chabot from RBC Consultants. Thank you for joining us this evening and welcome. Our webinar this evening is a patient's journey with atopic dermatitis. As guest speaker, we have Dr. Adam Friedman, as well as Dr. Jason Lee-Llacer and nurse Agnes Abedela. We'd also like to thank our sponsor, Roche-Posay, for making this educational event possible. Just a couple of technical tips before we start. If you're having any issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. Also, if you're having any technical issues or if you would like to submit a question to our panelists, please submit your question in the question chat pane on the right-hand side of your screen. At the end of the seminar, a survey will pop up in the web browser. Also, it will be sent to you following the webinar if you don't see it at the end of this webinar. Please fill it in for us. We truly appreciate it. Finally, within 1 to 2 days of the webinar, the recording of this program and a certificate of attendance will be sent to you. Again, if you want to ask questions, please submit your questions using the question chat pane on the right-hand side of your screen, and I wrote you a little note there to show you where to type it in. So without further ado, I would like to pass the floor virtually to Mr. Tyler Steele, Vice President and Medical and Media Relations at Roche-Posay. Tyler?
Hey everyone, thank you so much for joining me today. This is one of my favorite talks that we're able to give to you because it's about a non-surgical topical therapy, among other things, balneotherapy, and it's really around one of the programs that's near and dear to my heart. It's Dermatologist from the Heart from Roche-Posay. It's a grant program that sends patients to our partner clinic in Roche-Posay, France, where people are treated for various conditions, including atopic dermatitis, plaque psoriasis, and post-cancer radiation patients. The procedures are covered by insurance, so doctors like Adam Friedman in France can write a prescription. Obviously, if you're not a French citizen, it's not covered by the insurance, but in this case, our grant program does cover the costs associated with care. So we've been able to send a number of patients over the years. Dr. Lee-Llacer was a patient of Dr. Friedman's and had a tricky case. He tried a number of different things, which you'll hear about tonight. For joining our webinar and staying through to the Q&A, we really appreciate your time. So we're going to send you a gift bag that includes some Roche-Posay products, including Lipicar Balm and some other goodies that we hope you'll enjoy. We'll also be sending you a Roche-Posay hand sanitizer, alcohol-based hand sanitizer that hopefully will come in handy with keeping your hands health and safety during this time. So with that, I'm going to turn it over to our very special guest, Dr. Adam Friedman, Dr. Jason Lee-Llacer, and his primary care nurse, who's also his wife, Agnes Abedela. Thank you.
Thank you so much, Tyler. And I imagine Parisian Adam Friedman is much more fashionable and stylish than I am, so I can hang my head a little bit on that note. But we will go on and we will discuss really such an important topic in dermatology. And I want to echo the sentiments. Thank you for joining us on a Tuesday night to really go through several journeys, because I think all of our atopic dermatitis patients are on a long-term journey, as this is a chronic disease. And it is our duty and our privilege to help them along that journey to make it as easy as possible so they can enjoy the greater journey of life. Now, before I bring on our special guest, who you hear about firsthand, and I think it's a very interesting discussion as we have a patient spouse and caregiver, but also two individuals who are in the healthcare arena. And I know as practitioners, we are not always the best patients, and we don't often really find ourselves on the other side of the table. And so I think hearing their perspective is going to be very helpful when we even approach our own patients, both healthcare providers and other. So let's just jump right into atopic dermatitis before really hearing straight from the source. This is a chronic, relapsing, and I want to hit on pruritic inflammatory disease. And the pruritus of atopic dermatitis in all eczemas is somewhat unique. And as I'm sure many of you know, it's an itch that feels good to scratch. And that positive feedback perpetuates the itch scratch cycle, which further instigates barrier damage and perpetuating also inflammation. This is not a simple condition. It is a disease of nature and nurture. From GWAS studies, we know that multiple gene mutations are implicated. And if you were to kind of boil them down to two buckets, one would be within the immune dysregulation bucket and the other in barrier function, and we'll get into that. This is an exceedingly common disease. Eczemas overall affect roughly over 30 million members of the US population, and we boil it down to atopic dermatitis. It's still up there, high millions, and even in the moderate severe category, we're talking roughly 2.5 to 4 million individuals. So a massive population that really requires not just our assistance in the acute setting, but certainly ongoing. Now, in addition to kind of where this all comes from, nature and nurture, we can further dive down to the cellular level in terms of thinking about what's going on here. And it's really a dysfunctional relationship between decreased barrier function and complex immune dysregulation. And we'll get into some of those factors that play a role in kind of, and it's not independent. These are not two independent problems. They actually play on one another to perpetuate this condition. The impact should be obvious, but let's go into it anyway. The impact on quality of life is extraordinary, and I certainly want to give a shout out to my colleague at GW, John Silverberg, who has done a yeoman's work in elucidating a lot of these factors. Starting from left to right, there's plenty of evidence showing that individuals with ongoing and uncontrolled atopic dermatitis, but even controlled disease, have higher rates of depression and anxiety, as well as behavior disorders. One study in particular, which really, as a parent, stood out to me, looked at pediatric patients at different age ranges and looked for reports of bullying, social isolation, and ostracism. And there was a much higher percent, especially from bullying of kids aged 13 to 17 versus matched controls. And that certainly resonates, as this is already an awkward time in one's life, let alone throw atopic dermatitis to make a tough time even more complicated. The list of comorbidities is increasing, some of which are directly associated with the underpinnings of disease, but also are indirectly associated, one of which we can think about injury, bone fractures, motor vehicle accidents due to easy distractibility, but also somnolence associated with lower sleep. So it's not the direct biological impact of that chronic inflammation, but also what it does to us during the day due to what happens at night. So, and this is certainly a lecture unto itself, but I just want you to walk away from this conversation and this didactic, really always considering every atopic patient as an opportunity to improve someone's quality of life. So how do we then, in the context of this relentless chronic inflammatory disease that impacts daily activity, that makes individuals wonder when the next flare is going to come, how do we create an algorithm or a management strategy that reduces the severity of flares and also spaces them out? One study found that patients with severe atopic dermatitis literally had a flare every single month of the year. So how do we space that out? How do we allow patients to forget about that? Well, it's a complex approach, and it has to be a regimen. It cannot be a one and done, and that has to be part of the counseling and discussion. I would say that every new atopic dermatitis patient I see, I'm putting a good amount of time more on education than on what prescription I'm going to select, because really partnering with the patient and the patient's family or their caregiver or their spouse or family is really going to ensure compliance and success. As we know, compliance is one of our greatest struggles with getting patients to use treatment ongoing. Sorry for a skip. So we have some guidance in all this. In 2014, there was a 4-part series published in the JAD going over the management approach to atopic dermatitis, and this ranged from everything from topical therapy, and at that time, pretty much all off-label systemic agents. It is a little outdated, though I think what is very useful, just as an aside, that this series is that it does provide somewhat of a a step-by-step guide of how to do lab monitoring or starting a patient on a particular off-label immunosuppressant. I found that to be one of the greatest strengths of this series. For those who want to try something but don't have a lot of familiarity, it really does provide that step-by-step process to feel comfortable and know how to monitor these patients to ensure not only efficacy but safety. But certainly if you have not seen this 4-part series, it's worth checking out. Though there is a newer paper published in 2018 that describes from a therapeutic standpoint the AD yardstick, which doesn't just focus on acute approaches, which you see on the lower panel, but really takes into account the maintenance therapy. That what do you do for the active disease that actually gets better, and then you're managing those locations, but also accounts for non-lesional skin, because we know, thanks to work by Emma Gutman and Amy Paller at Northwestern, that even non-lesional skin has biologic abnormalities. On histology, there's spongiosis, there's inflammatory infiltrate, and we'll get into this also. The bacteria that live on the skin, those populations are disrupted. There's less diversity even on normal appearing skin. So we need an approach for the whole body, for even areas that look normal, because in atopics, even normal skin that appears normal is not normal. So I like this idea of kind of going up and down the stick, depending on severity, to beat AD back into submission. Now, with that in mind, how do we define a treatment failure? When do we decide to throw in the towel with a certain approach and move on? And the truth is, we don't have a set standard. I mean, even beyond that, we don't really even have a tried and true way to even diagnose atopic dermatitis. It's a clinical diagnosis. There's no biomarker. A biopsy only helps us put us in the eczematous category. But even thinking about when to decide to move on, we don't have great guidance. So this is hopefully going to share some of the more practical approaches, some things I think about, and some of these certainly are defined by the practitioner. So when we say inadequate clinical improvement, what do we mean by that? Do we mean that you tried something for several weeks and there was no response? Does it mean you tried something, the patient got better, and then after they stopped it, it came right back with a vengeance? Which I find more often than not is the case when a patient says, I've tried everything and nothing works. You need to follow up with a question, well, when you use it, did it work, but then did the problem come back? Yes, because I think that goes back to education, that patients assume that they treat the area, it'll go away and they won't have to deal with it again, but that often is not the case. So really, it's not just about does the medication work right there in the moment, but does it achieve sustainable results? Does the patient get long-term control with not just that treatment, but the regimen you're utilizing? No question, I find patient-reported outcomes with respect to the treatment regimens highly meaningful, and that's kind of the shift in even how we grade patients as mild, moderate to severe. If a patient's telling me, well, my skin's looking okay, but I'm not sleeping, I'm constantly scratching, I'm distracted, that to me suggests a failure. So I think there's no real generalizable approach. I think you have to tailor it to what the patient is telling you, but that's where the conversation really is quite important. I think when thinking about a topical, if you're going to decide whether or not it is effective in terms of treating that flare, I think 3 to 4 weeks is more than enough. And I tell patients, if they're not better from using a topical every day, twice a day for 3 weeks, chances are 4 weeks, 5 weeks, 6 weeks is not going to cut it. So that's also, I think, a good rule to follow when deciding whether or not you are going to switch gears and try something different. So let's get back into that pathophys. So I mentioned it's that really bad relationship that probably started on Tinder or in a bar between immune dysfunction and barrier dysfunction. Now, we know that this is a T2 predominant disease, and cytokines that are probably best known and visible from this arena would be interleukin 4 and 13, both of which can drive different elements of this disease, can initiate, but also perpetuate. Now, while we know that patients very often have various barrier mutations, whether it be filagra mutations, even occludin mutations, these are kind of like gap junctions in the epidermis that can be leaky, the immune dysfunction alone can create an acquired barrier dysfunction. We know that this immune profile can actually alter how the skin makes itself. It can suppress the barrier functionality, whether it be the physical barrier, the antimicrobial barrier, like antimicrobial peptides, but it also can alter another very important part of that barrier, which is the living, breathing microbiota, the bacteria that are part of that outer protective coating that keeps us safe from the outside world. And in that respect, you can think about how so many things from the outside world, going back to nature and nurture, how nurture or lack thereof, whether it be things we apply to the skin, the environment, and that could be harsh, dry winds, or even too much sun exposure, which could injure the skin. All these could theoretically be triggers for an atopic flare. So let's get into that part of the barrier I was mentioning, the living, breathing, very bountiful, we're talking about over 500 different species of microorganisms, bacteria on the skin that really play a role in conjunction with the structural elements, the stratum corneum and all the proteins and fats that go into making the cornified envelope. When everything is status quo, these organisms can actually play a role in regulating our innate immune system, keeping things in check, but also it can fight possible foreign invaders. We know that when provided certain elements like prebiotics, certain sugars, bacteria that live in our skin can make things that kill potentially harmful pathogens. So when everything's in check, when the petri dish, our skin, is functional, everything is nice. When it's dysfunctional, when there's a break in the armor, that's when you can get a shift, and this shift, not just a physical break, could be a change in the acidity of the skin. It could be a change in the ratios of various fats, and this will then facilitate certain bacteria to grow more than others, and that's where you get a decreasing diversity, and that's where you start to run into problems with dysbiosis and ultimately clinical disease. So we need to nurture the petri dish, and there are various ways we can certainly do that to maintain a healthy skin barrier that nurtures this part of the barrier as well. Now, we know in many inflammatory skin diseases, obviously the topic of discussion is atopic dermatitis, there is dysbiosis. And in fact, atopic dermatitis is probably the poster child with most of the research in the literature currently, though I will say psoriasis is certainly gaining some speed, as well as acne and rosacea. And what you're seeing here is the kind of percentages of the different phyla, the different organisms and their groupings in actually a patient with atopic dermatitis, unaffected to affected skin. You're seeing a lot of different changes in colors. And what you're seeing on the right, this increase to 33% of firmicutes, which include things like staph, this kind of goes skyrocketing. You're still seeing some abnormality and low diversity in the unaffected skin, which is important to note that even unaffected skin is affected skin in atopic versus someone who does not have atopic dermatitis. But really the key thing I want you to take away from this complicated figure is that you're decreasing diversity. You're getting more of several and the other populations are being minimized. And as diversity goes down, more problems go up. This is a study by Hadi Khan's group at NIH, which correlated diversity to clinical picture. And so what you're seeing here along the y-axis is the Shannon Diversity Index, meaning the diversity of these microbial populations, bacteria on the skin. And then SCORI, which is a validated research tool that literally scores the severity of atopic dermatitis. As you go up along the x-axis, the diversity goes down. And what you're seeing with the different colors, red stands for the flare, that the lowest diversity is going to be during an active flare of atopic dermatitis. Even more importantly, so yes, the question here, we're showing you, there's a decrease in diversity with active disease, but which is the chicken or the egg? What comes first? Well, they looked to answer that question. Same group showed that as diversity went down, this actually preceded, this was happening before you saw the clinical flare. So that diversity went down on the skin before you visually appreciated the active disease. And so it may be that this shift, this dysbiosis, precedes and fuels part of that inflammatory flare, and therefore could some strategy that maintains diversity, that maintains these populations in the proper amounts that they're supposed to be in, could that possibly prevent the next flare or even perpetuate and actually synergize with your clinical therapies? Now, another question we often get is, especially in children, is this going to persist? Is this going to go on? And is this truly a chronic disease? And the answer is maybe. The rule of the thirds, a third get better, a third stay the same, and a third get worse, still sort of stays true today. But we're starting to identify certain risk factors, such as later age of onset after 2, more and chronically more severe disease, as well as persistent disease, which kind of makes sense. And then this is a mishmash of several studies, population-based studies, that have been boiled down to those kind of 3 bullet points. But I think the main important thing to take home is this affects adults and kids. And of adults who get this, which there are certainly a good number and several million out there, roughly 10% get it for the first time as an adult. So don't let that age of onset dissuade you from considering something eczematous in that population. But no question, most adult patients with atopic derm have it since childhood. Last but not least, before we bring in our guests, I want to focus on that horrific, relentless, unique pruritus which is persistent, it's distracting, it keeps people up, but it is perpetuated by scratching. That the more you scratch, the more it itches. And what I tell patients often is that their skin is both genius, but also extraordinarily stupid, because it thinks they like to scratch. So more itch is generated. There's sprouting of unmelanated C fibers, and so that actually makes the itch even worse. The more you scratch, the worse it actually will get. So we have to break that cycle, and there are various ways we can certainly do that. And with that, I want to share a video with everyone, which I hope is moving a little faster on your screen than mine. But this is a video of a patient who is technically sleeping at 1:21 in the morning, who is clawing at himself and may still be asleep. And I find very often with our patients that we'll ask them if they scratch, and they say, no way, like it's a horrible admission. And then I ask, well, do you see blood on your sheets in the morning? And they say, well, yeah. And I say, you could be scratching while you're asleep and not even realize it. And I think that kind of clicks. Whereas if you just say, do you scratch, and they refuse, you can't stop there. You have to kind of elicit that maybe some of that scratching is happening at night, like with this patient who even, I believe on one hand may even have a mitten trying to limit the injury. But I think, this certainly is a disheartening and very upsetting video. This poor person cannot get any relief and is literally tearing his clothes off. So on that joyful note, oops, sorry about that. I'm going to welcome Jason and Agnes. I met Jason roughly, I don't know, what is it, a year and a half ago, 2 years ago, as a patient. As you heard, Jason is an ICU attending. Agnes is a nurse who actually has stepped away from her career to take on a new role as caregiver for Jason. That's how severe his case was. So welcome both of you. Certainly this would be more fun in person like it has been in the past, but this is the new normal and we'll take what we can get.
Yes, thanks for having us.
Thank you.
So just getting right into it, Jason, seeing that video of that poor guy just literally ripping himself apart, how do you relate to that? How did that make you feel?
I mean, that's my life. Definitely when I had my id reaction, I had a lack of sleep for, almost a year and a half, maybe 2 years. My wife, she had to.
Yeah, the picture you saw there was really him. And it's gone to a point that when he was sleeping, he doesn't recall scratching, but I would hold one of his arm and I see him scratching with the other arm, and I would hold the other arm and he would be scratching with his back and his head on the pillow. So really, that's really important to know with patients with eczema.
Yeah, even back in college, I was scratching like that. Maybe not as vigorously, but my roommate during a reunion had told me that I used to scratch vigorously at night, and I had no idea he could even hear all that.
And sometimes I would change the sheets maybe once or twice during the night, because when he gets up, he doesn't realize that there's bloody stains on the sheets, and I would change it quickly so that he doesn't see it and he doesn't feel bad about himself that he's, it's happening on his back like that. Yeah,
I think something you've highlighted is that this is not a disease of a solo island, that this condition affects everyone in the family. It can affect a roommate. And Agnes, I remember very clearly when we first met and started working together, you were laying to me how not only would you hold his hands so that he wouldn't scratch, but you actually even fan him to cool him off, because we know cooling can actually be quite helpful to just really distract from the pruritus sensation.
Not only fan him, but I would massage his chest or his arm, and I wouldn't sleep until he leaves for work in the morning. I would stay up all night and to make sure that at least he gets about 2 to 4 hours sleep at night, because I know he's got a long day to work.
Yeah, and I slept with ice packs. I slept with cool wraps. We had the temperature in the room like 64 degrees. So
fanning him at the same time.
And then when that didn't work, I would wake up and I'd take a scalding hot shower to feel pain instead of itch.
Yeah, I think we hear that a lot. I think it's so important for all those who are tuning in that you got to not just ask the patient what's going on and what they're doing, but also ask the, the family member in the room, because I think this does affect everyone. And I think that validation really engenders a good, physician, patient, family experience. Now, Jason, we talked about before how most patients who have it as adults, they have it as children as well. What are some of your earlier memories about your eczema growing up?
So as young as 3 or 4, I can remember always getting chased around by my family members trying to moisturize me because they just felt that my itch was due to dry skin. And during that time period, I was scratching vigorously in your typical antecubital areas behind the knees and my neck. And so every day I was bleeding. And so I would put like toilet paper to stop the bleeding. And they would chase me. They would put like Vaseline intensive care lotion, and to open wounds, those are very painful. So that made me equate lotioning with pain, and I didn't like it when I was young.
I think that's a good point. When we think about various vehicles, I often relate to patients goopy versus stingy. The more viscous ointment based can be very obtrusive. They can stain clothing and even furniture. They tend to sting less. However, creams can certainly be very irritating on any break in the skin, whether it be a small fissure to a linear excoriations that are weeping and bleeding. And I think that association will then limit the use of things that actually could help down the road. And think about down the road. So fast forward, you're an ICU attending, clearly a very demanding job. And we just heard that, Agnes had to literally quit her job to fan you and cool you off and make sure you don't tear your skin off and sleep during the night. But I imagine that sleep wasn't restful. How did it affect your role in a high stress and high anxiety situation as an ICU physician?
So, I don't know really how I made it through other than the support of my wife. As I stated before, I was sleeping maybe an hour or two a night for a prolonged period of time, at least a year, if not a year and a half to 2 years. And that obviously, affected, my wakefulness. But, I'm a pretty tough person. I just bore through it, but I could tell that I was more irritable because I wasn't getting any sleep. So, my temper would be much shorter than it normally would be. But it would definitely affect my work. So, I would still make, I felt sound judgments, but, I probably wasn't as patient as I would be normally.
And I'll ask Agnes, how then in parallel, how did this affect your social life, vacationing, even spending time together?
No, we did not leave the country. We traveled to New Jersey to visit my family, but in doing so, I would pack all the things that he needs. I would pack the ice packs. I would get the blanket that's soft to his skin. I would pack all his medications. Practically, we would fill up the car, the things that we would need to get to a place. But traveling even to another state further than New Jersey, I wasn't confident that he would be okay. So that really limited our vacation. We didn't take any like long-term vacations like we used to before.
Yeah, and just my regular daily activities, stuff that I used to do or enjoy, I wasn't doing anymore. Like I wasn't able to work out because the exercise, that I used to do would generate a lot of heat and then it would make me itchy. And so, that lack of exercise plus just the inflammatory response to my skin, I'm sure caused me to have like hyperlipidemia. And so I ended up going on statins and whatnot.
And also being around with other people, like friends. There was a person that I was friends with and told them, what do you have in your skin? What's happening to you? And he told them that it was eczema. I said, you're a doctor. You can't treat yourself. So, things like that comments with the people that we've met or, our previous friends was also, I think for me, it hurts me to hear those things about him. And so we work mostly with families instead. That's where we spend time with.
Yeah, I think the social stupidity factor certainly adds more anxiety and well, regardless of whether people are well-intentioned, that can add to the overall burden because anxiety increases itch, you scratch, furthers a flare or instigates a flare. So even, I think the visible nature of dermatologic disease, especially something like atopic dermatitis, which can be confused for many things like infectious diseases, can just even from an optic standpoint be very ostracizing and limit social engagements. And it's not like you didn't try to get this under control. I mean, your treatment regimen is one of the most complex that I've seen and have manipulated and worked with. And it took quite a lot to even get you some degree of control. When you see this list and this picture of the CVS that has become your home, how do you feel? What comes to mind?
So, when I initially was on all those things, I was thinking about side effects. I was worried about, am I going to develop, some long-term effects of taking some of these medications, where I develop, some renal disease, cancer, all these different things that, on any drug medication, there's a list of numerous side effects. The likelihood of you getting them is probably low in general, but, they're there. And, as a patient, whether you're a physician or not, you're going to have that, well, what if I get this, that worry about that. And I was just hoping that one day that, whatever it took, whether I took all those medications or not, at least I wanted to get my skin under control. And initially, before some of those medications, it wasn't.
Yeah. Hmm.
Yeah, and I think part of this regimen, which is quite complex. I think this is important for everyone here, is that it's not about trying something and then pivoting to something else. Sometimes you have to layer cake and add things on. A lot of what we're seeing here is going after the inflammatory response. Something you've noted that using things that can help with itch, like gabapentinoids, really was quite a game changer for you in order to be able to get some sleep and not appreciate that itch because of its impact on nerve transduction. So I think it's important to not just pile on, but also hit different elements of that condition. And another thing we need to consider, of course, is the barrier, and to perfectly pair that list of prescription drugs. You certainly have invested heavily in over-the-counter products too. How did you manage all these? How did you work this into your routine in terms of not getting a lot of sleep, going to work? When it sounds like you were bathing a lot to obscure the feeling of itch. How did this all fit in?
When you get home.
Yeah, I mean,
he usually gets home around 8:30 at night, and as he's driving, he would call me. I'm on my way home, and I'm starting to feel the itching now. So he parks and he runs right in to take a shower. So that's his first shower. And so he'll take about maybe half an hour to 45 minutes to put all the lotion, I'd help him lotion his back, else he do. And then he would have a meal, and before we would sleep at night, he would take another shower, because then he'll start to feel the itch again. And he goes through the same routine. So it eats up a lot of his time.
Yeah. I mean, as it would get better, I would try and take just the shower, more in the nighttime as compared to the morning time, just because it takes so long to put on all these different creams and lotions.
Yeah, and I feel like we went back and forth a lot, and what wasn't included in that list is, also you received a good amount of intramuscular Kenalog, usually every 3 to 4 months, which I found was also a marker, depending on how much we could space those out, how well you're doing. And so I feel like we got to a point where we've been trying a lot of things. You've been having some success here, and then it kind of flared. And so I think we got to a point where let's try whatever, let's try something different. And that's where I think the idea of having you go to La Roche-Posay, France, to the hospital, and technically prescribe a 3-week course, which I know you were only able to do 2 weeks at the hospital, which was a very time-intensive process. And I think it'd be great to hear from you of your experience there, what you went through, and how you think, especially from the perspective of a physician. Because I can imagine not knowing what balneotherapy is in advance, and hearing about all these high-powered showers and drinking, from an ICU attendee's perspective might sound a little off base, but sharing your experience certainly I think would be helpful for everyone here.
Yeah, I mean, I was open to doing all sorts of therapies even before going to France. So I've even done like acupuncture and whatnot. I've done other people's salves, and I was very open to do whatever we could to get this under control. So, going to France was an incredible experience, an incredible opportunity. I thank everyone that made that possible. And, so that was our first time going to France, and it was in the middle of France. So when you think about like, the countryside of France, this is it. It was very rural. People did not speak English, so luckily for us, we had a translator in the beginning to help us, get oriented with the treatments and get introduced to our dermatologists. And then thank goodness for Google Translate, because they could help translate us through, to get us, to survive living there for those 2 weeks. So here we have a picture of the center. So this is probably a picture of the pressure wash that they have, and we do that every morning. Is our first treatment, where they spray us down all over for about 2 minutes, I guess, just to kind of get that water to penetrate, I guess, deeper into our skin.
And so this might look a little familiar in terms of how severe you can get. And I would argue I've seen you even worse than this on several occasions. So in thinking about all the things you've been on and your experience in Paris, I'm sorry, in La Roche-Posay, which is not that close to Paris, but I think you got to go to Paris, which is nice. What was your experience? How did you feel in terms of this being kind of a new approach in conjunction and in synergy with your other therapies?
So when we first got there, I was in a little bit of flare because of the time difference, and that that stress on my body put me in a little bit of flare. And I got better even during the week. But what everyone always warned me about was after the first week, you're going to flare again, and which I did. And I was prepared for it, and it happened, but I did get better. And so, I was all in. I did everything that that I was told to do. I drank a whole lot of water, which was an interesting water just because of the thickness about it. It was kind of the viscosity was similar to kind of like milk, maybe not as thick, but it tasted fine. It wasn't like it didn't have a bad taste to it. It was just a different taste. So, but it's very interesting to drink.
I can imagine. So I think what we've seen in terms of your pretty impressive regimen going through this. I think we've seen progress, and something I'd love you to share you've recently shared with me is not only taking unique approaches in terms of your care, but also simple things, and changing your environment can play a big role in that you're finally able to switch your schedule and not work late and work more palatable hours, and how that has enabled you to actually reduce a lot of those medications. And I believe you said, and congratulations, you've not had an intramuscular ketamine injection for over a year at this point. So share a little bit about that, because I mean, that's also something we don't necessarily think about, but that can play such a big role in care too.
Yeah, so my last ketamine shot was April of 2019, and I would have flares even after that, coming up to La Roche-Posay, which we ended up going to at the end of September through October, or beginning of October of last year. And even before we went, I was developing a flare, and I just kind of grinned and bore it because I wanted to see the effects of what the balneotherapy would do. And it seemed to me that it has greatly helped me. So I definitely have had less flares since the balneotherapy. I've since coming back, even after January when I last saw you at another meeting, I've even had even less flares. So any of the flares I have been very minor. And just with the topical steroids that you've prescribed, it's able to control those flares. Luckily enough, I've actually been able to wean off of some of the medications that we'd seen in the previous slides. So I first was able to wean myself off the cyclosporin, and eventually during the summertime, I took myself, I think in June, I took myself off of methotrexate. And, you know,
Tolerating the
yeah,
sun.
and I've been able to exercise again. I haven't pushed it to super hard exercise yet, but you know, I've been able to go outside in the summer. You know, my heat intolerance is a lot better. So things have changed, you know, dramatically.
And we can actually identify some of the things that would cause him to flare, and that would be lack of sleep. And so with him changing his schedule, not having to work night shift, so his flares has really been less.
Yeah. And, you know, so I've moved to an employment model where I don't have to worry about how am I going to get this business to thrive. That's removed the stress. But, you know, we had a whole other new stress that came out this year with COVID.
What could you be talking about?
And so there was some flare, but not nearly what you would expect. Most of that came initially from having to wear those N95 masks all day long. I was able to get around that by now wearing a PAPR,
Yeah.
and that's greatly, you know, helped decrease the flares in my face. Because even the non, you know, atopic dermatitis people out there, I'm sure everyone has been getting different, you know, facial rashes or reactions from having to wear these masks.
No, absolutely. No, I'm so thrilled, obviously, to hear and be able to share your experiences and your successes. And you know, I want to kind of spend a couple moments talking about, well, why did this work? You know, why did you have this result from going even for just 2 out of the 3 weeks to the Roche-Posay hospital? And it is a hospital. I think it's important to note, you know, you kind of maybe envision it's a day spa. No, it's not. I've been there as well, and it looks like an old school hospital, and it behaves like an old school hospital, as I'm sure you guys remember quite clearly. You could see even in those.
It reminds me of old school gym. Gym lock.
Fair enough. So when we think about thermal spring water, which is what Jason was receiving, each spring water has its own unique biological fingerprint. And what you're seeing here is the makeup and composite of the Roche-Posay water versus another thermal water. And what you can note is that there's certain things that are present, such as selenium and strontium, and others that are in higher concentration. Now, one could say, well, I could just make this in my bathtub. Why can't I just put this together? That's actually illegal in Europe. In France, you can't recreate the composite of each individual thermal water. So you have to really go to the source. And given this has been of interest to industry for so long, we have a plethora of clinical studies and actually translational studies that are truly bench to bedside, showing the biological impact specifically on improving diversity in the microbiota on both normal skin, but also disease skin like an atopic dermatitis. So I just want to poke at selenium just for a second. There are some nice in vitro and mechanistic data that selenium is anti-inflammatory. It actually helps rejuvenate our inherent antioxidant system as well, which certainly can peter out over time, but also can be diminished by inflammatory skin diseases. It can protect our lipids, the composite of the cement that makes up the stratum corneum, the outer barrier. And there is even some suggestion that it could have some UVB protection as well. So a lot of preclinical evidence supporting its biological activity as an antioxidant, anti-inflammatory. Xanthomonas, I want to spend a moment on. This is a gram-negative bacteria, which I know as soon as we hear gram-negative, we assume something bad like Pseudomonas or E. coli. But actually, gram-negatives make up a small part of the microbiota in our skin, but they play a very large role in maintaining diversity. And we don't completely understand what Xanthomonas does, but what we do know is that when Xanthomonas goes up on the skin, staph goes down. So it may be that this particular gram-negative plays a role in orchestrating the various populations, of which there are many. We're not exactly sure how it does that, but there definitely is a correlation between normalization of the microbiota and that diversity that is so important to maintaining that healthy barrier. And in going back to that kind of thinking of the dysbiosis precedes the flare, one could then think about how if we were to rebalance the microbiota before you even see that clinical disease, and we know that with eczema, the name literally means to boil up, that it has to boil up before we actually see something. Could we re-engage that microbial barrier, balance it, and maybe there could even be some benefit to preventing that flare. And we have to foster it. It's not about just replacing the loss of those organisms. We need to give those organisms the tools to survive and grow the right way. And that's where prebiotics like thermal spring water that contains things like selenium and others are so important to really enhancing and maintaining the right amount of the right players on the skin. All right, I'm going to turn it back to Tyler for a moment to wrap things up, and then I will field some questions from the audience.
Actually, Dr. Friedman, we're going to go to questions directly.
Just kidding. We will go to questions directly. Let's see here. Okay, I recently read a study regarding preventing atopic dermatitis long-term in children by using moisturizer intervention the 3 months of life. Do you recommend this for families with atopic dermatitis is prevalent? Yes, there has actually been at least 2 studies I'm aware of, one in Japan, one in the US, led by Eric Simpson, where they looked at high-risk neonates, so babies born to families where there's a high prevalence of atopic dermatitis, and they slap, goop these kids like crazy, and they showed over a period of time that they reduced the incidence of new onset atopic dermatitis. I think they followed these kids out roughly 18 months to 2 years. Then there was a subsequent study that said, no, that's not true, but that study's been called into question. So I think the jury is still out to some degree on that. However, my question is, why not? You know, this is such a simple intervention. It can be an inexpensive one. And maybe taking a step further, knowing what you know about neonate skin, in that the pH is more basic than acidic, which we need it to be. That pH has to come down. It's thinner, and it barely has been touched by the microbial world. You know, really the kid's first exposure is going to be through vaginal delivery, if even that. Could then fostering the growth of the right organisms with a prebiotic, could that fast track that? And the answer is maybe. We don't know, but I think it's certainly worth going after. So thank you for bringing up those studies. I thought those were well done studies, but they were small in the scheme of things, but I think it's worth certainly doing. Oh, this was just a comment for our 2 guests. Just want to comment that it's truly inspiring to hear of the strength of the partnership among Dr. Lee-Llacer and Nurse Abedela. So, and I could not agree more. I am inspired, honestly, Agnes, by your dedication and investment in Jason's well-being, and certainly are a model for all of us. So I second that and echo it. Another question: will ensuring that your bath shower water is soft versus hard help? There is some data on soft water being safer, but really what it comes down to is what you do after the shower. That, you know, after you bathe, you don't want to dry out completely. You want the skin to be damp before you put a moisturizer on, because really what that moisturizer is doing from a historical sense is just creating a barrier, forcing water in so it doesn't evaporate and pull moisture from the stratum corneum with it. Certainly there are newer moisturizers that contain other things, as we mentioned, like prebiotics. But I think that even though there's some argument that maybe it doesn't make a difference, I am a strong believer moisturizer to damp skin. So I think that's more important than certainly the mineral rich, you know, hard water, where I think soft water will be a little gentler on the skin. Question: has a probiotic supplement been part of Dr. Lee-Llacer's treatment strategy? What does Dr. Friedman think about specific studies advocating for lactobacillus for atopic derm? So I don't believe you've been taking an oral probiotic. That said, there was a really nice JAMA Derm study, probably the best formulated clinical trial for a probiotic I've ever seen, that was published in a couple years ago, which was a combination of actually 3 probiotics that, using the various metrics we're used to, like SCORAD, showed a difference. The question to me is not, does it help? I think they do. The question is, which ones? And that's to your second part of your question. I honestly don't know, because even if you say there's a certain probiotic in a formulation, where's your quality assurance that it's stable, that you're getting a certain amount that's effective? I think the answer is they do something. Now we need good research to prove that they work. But Jason, I don't think you've been taking a probiotic, have you?
No.
Phew, okay, good. I know my patients. That could have gone a very different direction. So another question, was the application of thermal water effective for any other skin disease the patients concurrently had? I don't know, you tell me. Do you feel like it helped with anything else?
I mean, that's the only disease process that I had. I know that they use it for other things in terms of psoriasis. They use it for burns for cancer patients, whether it be from chemotherapy, or be for radiation, or from people that have had regular burns. So that is the dermatological center in France, and all these patients are treated there for these several different reasons.
And it's covered. That's what's wild, is that this is actually covered by insurance. There's even services where you could do a televisit with a cosmetic camouflage art. I mean, there are things that they're definitely ahead of the game than we are here. But yeah, I mean, patients can go repeatedly. I think it's approved up to several times a year, depending on the condition. But they do treat other inflammatory skin disease as well as wounds. Someone asked if you were on Dupixent. Yes, you are on Dupixent. Actually, I think you were on it even before I started taking care of you.
Yeah, I came on it as soon as it came out. I was able to go right on it. I think March in 2018 or whenever it first came out. Before you, I'd been seeing Dr. Ben Lokshin, and he was doing studies with it. That was one of the reasons why I first went to him, was because I knew he was doing studies with it, and I was trying to see if I could get on one of those studies. Unfortunately, it was already at the tail end of most of the studies, so I couldn't get on it at the time.
Right. Yeah, and another question came in. Obviously, there's a very rich pipeline with atopic dermatitis. I think probably the closest to market would be JAK inhibitors, and the question would we think about that in this case? I'm certainly, it's something we would entertain depending on your progress. I think the data has been very supportive. There's several of them, as well as topicals. So yeah, I think the good news is that we are going to have more systemic options that are actually meant for you, not just, hey, let's use this off label because it just blows out the immune system. So I think certainly I'm curious to see how that evolves, but also very excited to get my hands on more than one FDA-approved systemic agent for atopic dermatitis. The question was, someone asked about, you mentioned N95, that you're using a PAPR. Maybe you can explain a little bit what a PAPR is?
So it's basically a positive airway device. You can either wear a hood or a helmet. I purchased a helmet. I was lucky enough to get one during that really busy time. And the device that I have basically will suck in air through this device, and will go through a filter, go through the hose, and through to my helmet, and basically ensure that I'm not going to get unfiltered air going in through it. So it'll help prevent me from getting the virus in terms of inhaling it. I'm not exactly sure if it's dispersed elsewhere, and other people might be more. But it's kind of all connected to my my gowns and whatnot, or my clothing, so it would get interspersed into my clothes first.
The next question is, I'm going to address to both of you. As a patient and the spouse of a patient, is there anything specifically you feel dermatologists are regularly missing when treating atopic dermatitis?
So I've had a few dermatologists in my journey. Most of them were during this ID reaction, and I don't think they were necessarily missing anything. I think they were just going through the steps, kind of like what you had shown in terms of that stepwise therapy. I was already in that severe kind of case, so I went through the UV therapy. I went through all these different therapies. I think the biggest thing is making sure, how you were saying, that there's education involved. So you want to really have the expectations of educate their what they should be expecting in their journey, that this is not going to be a quick fix, that this is going to be through the long haul. This whole journey in terms of this most recent bad reaction I had has been about 3.5 years. You know, that in terms of, you know, that whole time for me to recover, and a lot of it was terrible. Like, I don't even know how I even made it through. I mean, I would prefer to go have intense pain over having intense itch. I mean, I had a kidney stone earlier this year, which is supposedly, you know, one of the worst pains you can have. That was nothing. I would take kidney stone any day over, you know, itching all night long.
And
That should be a
also,
quote on any website.
and also, I think the financial impact with the families as well is supposed to be, it's one of the things that we discussed about. So we were paying for our own insurance, and it was important for him to be on the highest tier so that he would be covered for all the medications and treatments that he needs to have.
Yeah, I mean, I'm fortunate enough to make a good living. There are many people that aren't able to make, you know, the living that I do, and, you know, their only source of, if they can't have insurance, if they can't afford it, is to hope that they can go into a study and hope that they are able to, you know, be in the non-placebo arm and that the treatment is effective for them. So I'm just fortunate enough to have all these ducks in a row and be able to get treated.
Yeah, I think cost is something we don't often think about, and is actually now part of the evaluation tool we use to evaluate residents in terms of being cost conscious and using you know, approaches that don't break the bank. That's actually something how we grade residents. That's a relatively newer addition to the evaluations, and I agree. I think we need to always be considerate of that. And there was one study that even looked at an array of moisturizers in terms of, to your point, you know, to the point brought up before, can you prevent possibly atopic dermatitis, or does it make a difference? And the good news is, as long as you're putting something on the skin, it'll have some impact. There probably are some that work better than others, but there are affordable options. And I think that's important to mention, also to think about when you're approaching a patient, and be mindful that it's easy to say something. It's another thing for a patient to go out and pay for the copay or pay for something over the counter. So I think that's important for us all to think about. We got a lot more questions. All right. Someone brought up neurokinin receptor inhibitors like aprepitant for itch. Yes, I think they do work, and the problem is cost. Goes right along with that, you know, previous comment. However, just a you know, kind of a practical note: the 80 milligram tablets, if you just order 80 milligrams a day, that will often get approved, versus the blister pack, which is 3 doses a week. That's meant for nausea-associated chemotherapy. So I just recently found that out, but I think it is a useful tool for itch as well. Let's see. This actually might be a question for Tyler. Someone asked about the various La Roche-Posay products and how they're viewed in terms of their role for being adjuncts or proactive parts of the management strategy.
Well, probably a question for both of us, because I don't want to be overly commercial, but I would say, as someone who's worked in skincare for a long time in both pharmaceutical companies, including Galderma and L'Oreal, and as someone who's worked with skincare people, you know, or skincare for a long time, adjunctive therapy plays a role. I know a lot of times doctors are thinking about drugs and the changes of drugs and the comorbidities and all the different things that Jason talked about when you have to think about everything you're on and the ramifications they can have. But certainly the role of the barrier, the role of soothing skin, the role of helping a patient relieve that itch and give them something to reach for to help control can be important. I would say as more drugs also go over the counter, you know, for things that are accessible to patients, certainly in the space of acne and other places, it can definitely provide a role. I don't want to linger too long on this, but I always say to people, and I think a lot of people agree, you know, Americans are a funny species, you know, like they have no problem going to a dermatologist and paying thousands of dollars for Botox or a filler, but you slap them with a $30 copay, or they learn that they got to pay $60 for something out of the pocket, and they absolutely freak out. So, you know, brands and products that can prove that they have a place, I think definitely have a role. And, you know, challenge us at La Roche-Posay. You're our only customer. We don't really advertise. We're a word of mouth brand. So anything that we can do to support the needs of you and your patients, challenge us to deliver what we can to help you make your patients compliant and ultimately improve their quality of life.
Just to add on to some, personal practical pearls in thinking about Tolarian versus Lipicar, I find Lipicar is a little thicker. Also, Lipicar has a postbiotic in it. We mentioned prebiotics, which is the fuel. Probiotics are the living things. Postbiotics are either heat-killed organisms or they're something that a microorganism secretes that can have a biological effect. And there is some data on this particular postbiotic in Lipicar by Rich Gallo's group showing that it can actually induce Tregs, regulatory T cells that can help minimize inflammation. Obviously, we don't make any drug claims here, but some nice preclinical data. So I tend to turn to Lipicar more for body, whereas Tolarian I think is a little more versatile. It doesn't have to really just be for atopic dermatitis. I recommend it for other primary skin diseases, but even just typical care. So I hope that's somewhat helpful. I have another question for Agnes and Jason. Along the lines of the previous comment about cost, have you identified any tricks for, in terms of managing the cost of the products? I mean, you had an entire counter full of products, forget even the copays of all the prescription medications. What tricks did you pick up along the way that we can maybe share with patients to make it easier for them?
I mean, other than grabbing a handful of free samples from the dermatologist's office?
I'm pretty sure I gave you them in giant bag. You did not have to steal them, okay?
Yeah.
In terms of decreasing costs, Costco is my go-to for shopping everywhere for everything. So in terms of like some of the creams like Cetaphil was something that I use a lot that I get from there. I haven't seen Eucerin there, but I like to shop wholesale and buy in bulk in general. So if you can find the creams that work for you at a big wholesale type environment, then you're likely going to save. And always try and buy it when it's on sale. So when things are on sale at Costco, they're really on sale.
And also the Dupixent that you order.
So and then Dupixent, which I'm on, has their own it has their own patient assistance program as well. So along with your insurance, the patient assistance program can help pay for those costs.
Great, thanks guys. I have a couple of questions that came in about bleach baths. And right, we're talking about supporting the microbiota, and bleach kills everything. So how do you reconcile the two? So there's actually been kind of a story developing here that we first thought that bleach baths, which is a quarter to a half cup of bleach in a full bathtub of water, 40 gallons, that was working by killing staph on the skin, and that you maintained a decreased level of colonization. That's why it had an effect. Fast forward to a JCI paper by Tom Leung's group showing that hypochlorous acid, which is what bleach turns into when it's in water of a certain pH, has anti-inflammatory properties. And actually, when you put that little bit of bleach in a full bathtub, you're really getting like 0.004 plus minus %. And then the next part of that story was, I believe it was John Silverberg and his team, or maybe someone else in Northwestern, that showed that concentration, it's not antimicrobial. So it may be that at this low concentration of hypochlorous acid, you're having an anti-inflammatory, antipyretic effect versus actually killing anything. So I think the story is still unfolding whether or not bleach baths actually kill what's on the skin, rather than working through anti-inflammatory mechanisms, specifically through inhibition of the NF-kappa B pathway. So yeah, I think you're right. At face value, thinking of things that we do to our skin, antibacterial washes, chlorhexidine, benzoyl peroxide, these certainly will disrupt the microbiome. Do these bleach baths do that? It's unclear. We don't know. So that was a good point to bring up. I certainly do use those, and I also use some of the stabilized hypochlorous acid formulations that are available. Let's see, other questions. Yes, I do believe in wet rep therapy. I think it's great if you can get a patient to do it. Jason, did you ever do wet rep therapy?
Yes, in terms of, I used to sleep with a t-shirt, wet t-shirt. I'd wet it, and about an hour or two, it would be completely dry. And so then I would have to go wake up and re-wet it again. But yes, I did use that, especially when I first had my id reaction.
Someone asked, what has helped you the most for itching?
My wife.
Me.
Good answer.
You know, I really, I
That should be the
think
answer for anything, right?
yeah, this is a routine. It's really, I put pressure on him the whole night that I really have good massage
She has
skills
Popeye
now.
forearms,
I
yeah.
have big forearms, and by doing this, actually, it takes away the itch and the stimulus for him to scratch, because then he focuses on the pressure of the in his skin rather than having to scratch that area. And that helps him a lot all night, or I would rub his back all night or his neck.
So for those that are not fortunate enough to have someone like my wife, the gabapentin has helped a lot. You know, I even before you put me on it, I was always thinking of either that or one of the other type of drugs like amitriptyline or Lyrica, just because I felt that the pain fibers and its fibers are very similar. That was the reason why, even though it was probably detrimental to me taking the very hot showers in terms of losing a lot of moisture from my skin, that was one of the things that took the itch away, because I would have intense pain, and that was better than the itch.
Now, thinking about pain, so someone brought up that point about you would choose pain over itch, but beyond that, has your atopic dermatitis ever been painful? Is that part of your symptomatic repertoire?
I mean, it's always had like wounds, and the wounds can be a little bit painful, but you know, the itch is worse. But obviously, when you go through that itch scratch cycle, you go to this point where you're not itchy anymore, but now you're left with the wounds, and you know that they're unsightly and they can be a little bit painful, but the itch is worse.
Yep. And actually, there's just a paper published in this month's Journal of Drugs and Dermatology evaluating pain in atopic dermatitis, which I think to that point, the itch is so overwhelming, often pain is not considered, but this can be a very painful condition, especially fissures and open wounds that often we forget to ask about that and even consider the pain associated with applying topicals. Did you find, I mean, you mentioned that as a child, but even now, did your selection of over-the-counter moisturizers, was that dictated by which ones stung and which ones were tolerable?
No, this time, like as an adult, they were never like stingy for me. Fortunately, I don't know if Vaseline Intensive Care in that white bottle was more stingy than any other cream, but I was terrified of that lotion, just because of my childhood. Even before the creams, though, in terms of pain, before I had my id reaction, I would have like really, bad hand eczema. I had like palm flicks. I'd have lichenification and the cracking, and so there'd be discomfort and pain from that cracking in my hands, which was obviously worsened from my profession where I had to clean my hands so very often. But yeah.
All right, we have time for one more question, and I don't want to underestimate all the contributions. We had a ton of questions, and I'm going to see if we can maybe answer some of these post-talks. So thank you for all of your contributions. But the question I want to ask is actually for both of us. And someone raised the point that many of us were trained in kind of reductionist pathophys and etiology of disease and its treatment. The simplest answer is the best one. The simplest treatment approach is going to be the best adhered to and most effective. And I'll start with you, and I'll share my 2 cents. Has this experience with Roche-Posay, balneotherapy, fostering the skin microbiota, something you may never have thought of before as an ICU attending, has this changed your approach to more of a holistic view and a more complex view of disease in itself?
I think I've always been open to all these different therapies because of the disease process. Now that I'm seeing the results, I'm probably even more open to having more alternative treatments. But once you're to the level where I was at, you're desperate to find some sort of cure or some sort of treatment that's going to be effective. And so, for any patient that has met all the traditional means, or at least the Western medicine means of doing things, they're going to go and look elsewhere if they haven't found what they're looking for.
Yeah, I mean, I think that we inherently want the explanation of why disease happens to be simplistic, that from start to disease, we can really explain it and understand it, and also be able to explain it easily to our patients. And when you have a condition like atopic dermatitis, that while yes, there's two major factors, barrier dysfunction and immune dysregulation, there are so many peripheral factors that play into that, including the impact of that inflammation on the microbiota, but also the impact of the microbiota on the barrier as well as the immune system. And even just looking at the storyline of atopic derm, first, historically, this is a disease of immune dysfunction. Then we discover the filaggrin. I say we, Peter Elias and folks at West, identify filaggrin mutation. All of a sudden, it's about the barrier, it's about filaggrin and ceramides and all these barrier repair devices, yippee. And now we're back to immune dysfunction. And I think that storyline is very poignant, especially when it comes to inflammatory diseases, that these are complex, that it's hard to really boil them down to something simple. And I think, to really find solutions that will achieve ongoing clearance, we need to be a little more holistic. And, certainly as someone with a science background, being in the lab, that goes against everything that I would really want. I want a kind of linear way of approaching things, but no, I've definitely become more holistic, both in my understanding of the disease and how I teach it to residents and colleagues and talk about with colleagues, but also how I approach treatment. As you saw with that picture, we were hitting this with gabapentinoids, anti-inflammatories, topical moisturizer, barrier protectants, you name it. So I think you have to take a very holistic approach, not always, but I think for this, you have to. So thank you for raising that question. All right, I think we're gonna wrap things up. Thank you, first of all, so much, Jason and Agnes. First off, for sticking with me and not rolling your eyes when I suggested you should go to the Roche-Posay Hospital and giving it a try and really experiencing it firsthand, and then of course sharing it with everyone in the role of fostering the microbiota and its important role in managing this disease. Thank you, Tyler and Roche-Posay, for supporting this program. Roxanne, always a pleasure working with you and your team. You are a rock star. Thank you. And to everyone, good night, be safe. And I'll turn it back to Roxanne to wrap up.
Well, thank you, everybody. And thank you so much, Dr. Friedman and Dr. Jason Lee-Llacer and Agnes. Truly a pleasure always to hear your journey and your stories, and so informative and so compelling. So thank you for sharing this with us this evening. And we wish you all a good evening and be safe. Bye-bye.
Thank you.
Thank you, everyone, for letting us tell our story.
Thank you.
Bye, guys. See you soon.